All right, welcome back, folks. Very excited to have you here joining me. This is Dr. Gatta, board certified prosthodontist. Thank you for joining us on the Implant Prosthodontic YouTube channel. What better way to get ready for the holidays than talking about implant overdentures? So today's case, we're going to be looking at an individual who presented with maxillary complete edentulosum, mandibular partial edentulosum. The initial treatment plan was to make a trial denture and do a single unit implant site 30, 2 FDP bridge restorations in the anterior and posterior left sextants. Once those were done, well, let me back up. They were done concurrently, and I wanted to do that so I could build the occlusion at the same time in terms of prepping the mandibular teeth, making sure I had room to set a 20-degree template occlusal curve of SPE, getting everything nice and appropriate, and also, again, border mold, get your maxillary impression, functional posterior palatal seal, account for any shrinkage of the acrylic. That new trial denture allowed me to test the phonetics, aesthetics of a person who has not worn a restoration in a while. Also allowed me to make a radiographic guide from that. I made a surgical guide from that. From that, we have the delivered mandibular restorations. Still waiting to deliver the single unit there. Once the CBCT three-dimensional radiograph was made, I could only get 3 implants in the anterior region. Patient refused augmentation of the sinuses. I did not lean the implants for an increased AP spread. That probably would have been an option. My surgeon and I didn't feel comfortable doing that. We ended up with 3 implants. And patient is a diabetic, so the gingiva is not in a really great condition. It's pretty edematous and usually always irritated from the healing abutments here. So I wanted to bring the restoration off the gingiva, and a bar is a great way to do that. One thing with the bar, though, you got to mind the restorative space. There's a great article out of Tennessee from Dr. Cagna looking at restorative space, and these silicone matrices are crucial to help you determine your restorative space. And you can see pretty quickly how high the restorative components stack up here. I mean, with the healing top of the locator already about 7-8 millimeters, you got 2 millimeters of your acrylic and room for your teeth. So you really got to plan accordingly. This patient has atrophied so much that I was really confident I would have the room I needed. Silicone matrices were made to confirm that. This restoration is pretty slick. It's palateless, metal reinforced, but yet there's acrylic on top of the metal, so I can do future relines. Metal stops in the posterior region. 3 locator abutments milled into the bar for great retention. And you can see the lab did a pretty nice job of following the contour of the incisal edge that I wanted. Now this incisal edge was achieved from the trial denture the patient's currently wearing, tested by phonetics and aesthetics. Also, I always send the lab one of these putty remounts to make sure they're honest and kept close there. One thing you may not think about is a palatal restorative guide check. Again, looks at your palatal space. They violated it a little bit. I mean, this is right up against the bar, so this restoration is going to be a little bulkier than what the patient is currently used to. So we're reaching about the most people's attention span. We're going to go ahead and wrap it up here. Really appreciate you guys checking this out. Go ahead and follow me on YouTube, Implant Prosthodontics Facebook page on Facebook, Instagram, and any other social media platform. I'm probably out there trying to reach people. You guys have a good holiday, and please submit your questions if you're looking for future topics. Take care. Thanks.